Learning objectives. So by the end of the session, we're hoping that you'll leave with 4 unique things. One is to be able to describe the local context for the ISPA and the record review process for this year. That you'll also be able to assess a historical immunization record to determine what vaccines should be administered to patients. That you'll be able to develop a schedule of vaccinations for patients and their families with more complex immunization records that would bring them up to date. And finally, explain to patients and their families the process for reporting vaccine-related information, including where and how to submit records, and the importance of doing so for public health monitoring. And just wanted to let you know that all data, resources, and recommendations presented are based on current scientific literature and data. And now time to test your knowledge. So if you can go to Menti, just on your browser or on your phone, just type in menti.com. And there's a code you're going to use. So once you're at menti.com, you want to use the code 65211839. That code once again is 65211839. Okay. Just so you're aware, this is the first time IT has had Menti use since we converted to 365. So we're having a little bit of fun tonight, but we'll get you that. There we go. Okay, so I'm hoping everyone sees the question. Please rate your confidence on a scale of 1, not confident, to 5, very confident. And go ahead and start populating your responses. Oh, there we go. So just give everyone a few more minutes to add in. Okay, should we move on to the next question? So that's good. We're about midway. Which of the following describes the role of healthcare providers in the ISPA? A, to explain to patients and their families the process for reporting vaccine-related information to public health. B, to ensure students are immunized against designated disease for school attendance. C, to complete a medical exemption for a patient when the vaccine is deemed to be unsafe or unnecessary. Or D, all of the above. Okay. Just give people a little bit longer to. Okay, why don't we move on to the next slide? A patient's records show they've received Tdap IPV Hib at ages 2, 4, and 6 months. What is the next recommended dose based on the publicly funded schedule? A, no further doses needed. B, booster at 18 months. C, booster at 4 to 6 years. And D, both B and C. And we'll move on to the next slide. True or false? If a child can't find their immunization record, I should order serology to see what they are immune to. True or false? I'm just reading the comments. Okay, we'll move on to the next question. Thank you. Where should parents, guardians submit updated immunization records for school-aged children in Ontario? A, to their child's school, B, to the local health unit, C, to their family doctor only, D, online using Immunization Connect or ICON, and finally, E, B or D. That's a skill testing question, that one.
Those functions in the chat here.
Okay, let's move on to the next question. Oh, this is the last question. Never mind. So we're going to close out of this Mentimeter and get back into the presentation. You have the sound on? Okay, so we're going to hand it over to Dr. Ma.
Hi, everyone. Can you hear me? Okay. My name is Angela Ma. I'm a fifth-year resident in public health, and I'm also a family doctor. I'm on rotation right now at Niagara Region Public Health, so today I'm going to talk to you about the local context for ISPA, or the Immunization of School Pupils Act. Next slide, please. Sorry, I don't think I can. Thank you. So just some disclosures to start. The program is hosted and organized by Niagara Region Public Health, and I have a financial relationship as an employee with Kingston Health Sciences Center and Kingston Community Health Centers. In terms of potential for conflicts of interest, Niagara Region Public Health receives funding from the province of Ontario, which also provides funding for public health research programs and resources that may be discussed today. So ISPA, or the Immunization of School Pupils Act, is a provincial law which requires that students attending school in Ontario have to have an up-to-date immunization against certain designated diseases or a valid exemption on file with public health. The purpose of the ISPA is to enhance the protection of children's health against 9 designated vaccine-preventable diseases. So the diseases that require a complete immunization record or a valid exemption are listed on the screen there. And to just go over the process, every year, Niagara Region Public Health reviews all cohorts of school-aged children, so aged 4 to 17, and any families with incomplete immunization records will receive a reminder letter from Public Health specifying what ISPA-related diseases their child is not completely immunized for. For instance, the vaccine or the letters will state that the student is missing vaccine for tetanus, diphtheria, and pertussis instead of specifically saying a vaccine like DTaP, IPV, HIB, or Tdap. Even if your patient is fully up to date, they will still receive a letter if their vaccines were not reported to public health. ISPA also gives the local medical officer of health the authority to order the suspension of a student from school if they don't comply with the act. So families that continue to be non-compliant are issued a suspension order, and they're given time to update and submit their records before the suspension period begins. Throughout this entire process, healthcare providers play an important role in determining why a child's record is incomplete. Sorry, I'm having tech difficulties. Okay. So I just want to highlight the provincial measles outbreak as one of the ways that ISPA the importance of ISPA is exemplified. So ISPA is critical for documenting the immunization status of school-aged children, and that allows us to respond to outbreaks to protect the community. In the provincial outbreak, 25 health units were impacted, but what you see on the screen here is just the health units that were most affected and then Niagara in comparison. So Niagara had 13 outbreak-related cases, and by using immunization records and exemption data, public health was able to promptly identify and follow up with those individuals at risk, and where necessary, exclude any susceptible individuals. By having accurate and up-to-date immunization records, we were able to respond timely and effectively, which protects both students and the broader community. Just to share some statistics from last year's ISPA process. So the highest number of immunization reminder notices were issued to grade 2 students, followed by junior kindergarten. And notably, high school students, grades 9 to 12, accounted for 37% of all reminder letters distributed within Niagara. The grades receiving the most letters aligned with the age ranges targeted by the Ontario vaccine schedule, so that suggests that future efforts should really prioritize catching up students in those grades and the years just before. In terms of diseases, the most common diseases for which reminder notices were issued were pertussis, diphtheria, and tetanus, and the least common was rubella. And then with respect to suspension orders, even though high school students received a high number of reminder notices, they actually experienced a low number of suspensions in comparison. So that really demonstrates the positive impact of having efforts like vaccine clinics in updating student records and reducing those suspensions. In terms of year-to-year trends, over the past several years, public health has found an increase in the number of incomplete or out-of-date records with students in Niagara. And that increasing trend just poses a threat to the community health and puts students at risk of school suspension. Leslie will expand on predictions for this year, 25-26, during her presentation. So we're currently undergoing a comprehensive review of the ISPA process with the goals of identifying opportunities to make the process better, improve service, and also operational efficiency. So we applied a SWOT analysis framework, so strengths, weaknesses, opportunities, and threats, and some of the themes are shared on the slide here. In terms of strengths, we've identified strong partnerships with public health, healthcare providers, and schools. School-based vaccine clinics as a means of access, and then also various methods through which clients are able to report their vaccines through public health. In terms of weaknesses, there are incomplete or missing immunization records, a lack of awareness on the part of parents and guardians on the requirement to report, larger school-age cohorts, so many more individuals for which this process needs to be undertaken, and misalignment between the federal and provincial vaccine requirement guidelines. In terms of opportunities, we identified potential for improvements to communication out to parents and guardians. And one example of that would be the potential for translation tools to be used to support individuals with language barriers. And then ongoing advocacy to ministry for improvements to ICON, which is the portal through which immunizations are reported. In terms of threats, we're seeing frustration in securing vaccination appointments, anger at use of the word suspension, and then, of course, vaccine hesitancy, which we'll touch on later on in this presentation. If we take a look at vaccine preventable disease rates in Niagara, so we're looking at the teal line, which represents Niagara region, and then just to note that these counts or these rates include diseases that are beyond those 9 that are required by ISPA. But overall, we see a steady upward trend since 2021, and we see a similar trend at the provincial level. We can see that Niagara also has slightly lower rates of vaccine preventable diseases compared to the provincial average. This shows us immunization coverage rates for students aged 4 to 17 in Niagara. This data was pulled at the end of October. Previously, we had a national target for 95% coverage for all routine childhood vaccinations by 2025. So we can see that Niagara is just under that target. In terms of medical exemptions in the region, the number is fairly low. Here is a chart of the medical exemptions for the past 3 immunization record reviews. So there's 2 numbers for every year, one in the spring, one in the fall, and then one in the spring, which is a pre and a post. And then just for additional context, the total student cohort is over 71,000 individuals. So these numbers are very small. If you do need to complete a medical exemption, this would be done if a vaccine is deemed to be unsafe or unnecessary for the patient, might be due to medical contraindication, lab confirmation of immunity or prior disease, or clinical diagnosis of prior disease. And that is a ministry form that can be signed by a physician or a nurse practitioner. On the other hand, families who request an exemption for philosophical or religious reasons will need to complete a vaccine exemption statement, and these families should be referred to public health. One of the reasons why some students are missing their ISPA vaccines is related to vaccine hesitancy. And the graph on this slide is from the Angus Reid Institute, and it's just showing that vaccine hesitancy has risen since the COVID-19 pandemic. So in 2024, only 67% of Canadian parents said that they would vaccinate their children without hesitation, compared to 88% in 2019. To better understand healthcare provider experiences locally, Niagara Region Public Health conducted a vaccine hesitancy survey from July 31st to September 30th of last year. So the most common reason for vaccine hesitancy was fear of vaccines causing harmful or unsafe side effects. And the next most common reasons included lack of trust in government and healthcare providers in the pharmaceutical industry, concern about ingredients and chemicals in vaccines, and concern that some vaccines are too new and lack sufficient research. That survey also identified challenges when working with vaccine hesitant patients. So challenges identified by healthcare providers. And so you shared that patients who have made up their mind are not open to new information and sometimes have a confrontational attitude, making conversations difficult. Providers have to counter social media and misinformation from other sources that are not reputable, and also identify that it's very challenging to stay up to date on new information and to answer very specific questions that families and patients may have. Over 75% of the respondents felt that they could benefit from more resources and information to help them respond to vaccine hesitancy more effectively. So in response to this, public health created resources for healthcare providers specifically to support conversations about immunizations. So one of these resources was this badge card, which is presented on the slide. The card contains key messages about starting the conversation and then strategies to respond to vaccine hesitancy. And the QR code on the card takes you to the vaccine hesitancy page on our website, which expands on some of these recommendations. Cold chain nurses will also be bringing copies of this card to clinics during their 2026 inspections. And we'll be monitoring interest in this resource, and based on interest, we may make this available to order on our website for any clinic staff. To focus in on some of these recommendations, so when offering immunization to patients, making a strong recommendation, so patients are more likely to choose to vaccinate when their healthcare provider strongly and confidently recommends it. Taking a presumptive approach, so saying things like, your child is due for the following 3 vaccines, or if you haven't had your flu shot, we can give it to you today. Statements like that have been shown to increase vaccine uptake, and then offering again. In terms of responding to vaccine hesitancy, listening to what your patient says, showing empathy, affirming their feelings and validating emotions, supporting their autonomy and reinforcing that the choice to vaccinate is up to them, asking permission to share information about immunization, and if their response is no, move on. If your patient agrees, then share that information and focus on the specific concerns or topics that were brought up by them. And then ask your patients what they will do with this information, and if they do choose not to immunize at that time, respect that decision and offer continued support for future questions. Since one of the most common concerns people had was around harmful or unsafe side effects, I wanted to highlight that we also have a handout on caring for your child after vaccinations. So that handout reviews common and rare side effects and what to do about them, and then also provides information on how to report adverse events. The handout is available to order on our website, and you can give it to patients following immunization. And then to finish my section of the presentation, I'm just going to play a 5-minute video from Sick Kids about CARD, which is a vaccine planning and delivery framework. This works. Let us know if you
Breakthrough
cannot.
AI inference speed is here. Large context AI solutions require fast outputs, massive throughput capacity, and resilient scaling to be successful. Crusoe Managed Inference is built with cutting-edge technology and fully managed endpoints, so you can run model inference faster.
Using CARD in your vaccination program. How vaccine programs and providers can play their cards to improve the vaccination experience. Did you ever wonder how you could make getting vaccinated a better experience for everyone? Vaccinations can be stressful and concerning events, but it doesn't have to be this way. The way vaccines are delivered can cause many people to experience fear, pain, and other reactions, such as dizziness and fainting. Experiencing these stress-related responses complicates vaccinations, leads to longer appointments, and causes some people to avoid vaccinations in the future. Concerns about needles are common. 2 out of 3 children and 1 out of 4 adults are afraid of needles. 1 out of 10 people are not vaccinated simply because of concerns about needles and pain. We have a way to help. The card system is the first and only vaccine delivery framework proven to reduce fear, pain, and other stress-related responses in children and adults. Every letter in the word card represents a strategy that clients and staff can do to improve the experience. C is comfort, A is ask, R is relax, and D is distract. Comfort strategies include ways of making clinics welcoming so people feel at ease. The Ask card invites people to ask questions about the issues that concern them. Relax strategies help people stay calm. And distract strategies take people's attention away from what's happening. CARD is effective across vaccination settings, including vaccinations delivered in schools, vaccination clinics, and community pharmacies. CARD improves the safety of vaccination delivery. It reduces fear, pain, and stress-related responses that are precursors to fainting injuries. It saves time during vaccine injections and leads to more positive experiences in vaccine clients, vaccinators, and onlookers, including caregivers and clinic staff. CARD includes interventions that address the psychological, biological, and social factors contributing to an individual's risk of experiencing stress-related responses. These interventions include increasing knowledge and preparedness, reducing pain and fear, and promoting trusting relationships with staff. A free integration guide is available that spans all aspects of the vaccination process, from vaccination planning to administration activities. It starts with preparing your staff. Educate yourself and your staff on what CARD is and what you want to do to integrate CARD, including how you will prepare your clinic and which resources you will use. Review this implementation toolkit with your staff. It can help you and your staff with clinic planning. It includes tip sheets, checklists, and materials you can use to set up your vaccination area to make it more comfortable and inviting. Once your team is ready, you can put your CARD plan into action. From scheduling to check-in, vaccine clients can receive information about CARD, including a CARD checklist that gives them choices about how to make vaccination more comfortable for them, including what they can do, what to bring, and what may be available at the clinic. Remind clients that they have choices. Then display resources and distraction items and make them easily accessible in the waiting area. When it's time for vaccination, show your support. Use your client's coping choices from the CARD checklist to guide your interaction and be ready to assist. What you say and do makes a big difference. The aftercare area provides you and your staff the opportunity to ask your clients about how they're feeling. A quick survey can inform you about their experiences and what can be done better the next time. Your team provides important feedback too. Ask staff about their experiences. Use all the feedback to make improvements for the next time. Ultimately, CARD facilitates a more person-centered approach which promotes client and staff satisfaction and positive attitudes about vaccination. The CARD system is aligned with national immunization policies and competencies. It is also consistent with vaccination administration guidance by the World Health Organization. Adopt the CARD system and join healthcare professionals in making needle procedures more person-centered and positive across generations. All CARD resources are freely available at cardsystem.ca for distribution and use, electronically or in print. Visit cardsystem.ca today to download the CARD integration guide. For more resources and scientific evidence supporting CARD, visit cardsystem.ca and helpneedlepain.ca. The CARD system was made available with support from the public.
Okay, thank you, Dr. Ma, and good evening, everyone. My name is Leslie, and I'm the manager of the vaccine program here at Niagara Region Public Health. In this next section, I will be going over the record review process for the 2025-26 school year. And I'll also be explaining the process for patients and their families to report vaccine-related information to public health, including where and how to submit the records. Don't know. Sorry, I'm trying to advance the slide. Okay. First, I just wanted to review the disclosure for both myself and Jenny, who will be presenting just after me. Thank you for attending this education session this evening. Both Jenny and I are paid employees of Niagara Region Public Health, and Niagara Region Public Health receives funding from the province of Ontario, who also provides funding for public health research programs and resources that may be discussed today. Okay, next slide. Okay, to get started, we thought it'd be helpful to do a quick review of what happened with the last record review before we get into the current state predictions and timelines for this year's annual immunization record review. This will help provide a sense of the scale of immunization record review in Niagara. This slide outlines a high-level overview of the 2024-25 Immunization of School Pupils Act enforcement, otherwise referred to as ISPA, throughout this presentation. And it's reflective of school-aged students 4 to 17 years of age with incomplete immunization information on file with public health who were vulnerable to or for exclusion from school. It's important to note that there were significant outreach efforts in place to reduce numbers before the immunization record review period began. For example, in June of 2024, Public Health sent out just under 2,100 letters to students attending school with no immunization information on file with Public Health. And we also reached out by phone or in person through outreach at school to just over 1,500 students who had no immunization records on file during the months of November and December. That was late in 2024, as the Canada Post strike did cause a delay in sending out immunization reminder notices to families. So we started with a student cohort of just over 71,000 students. 13,719 students from this cohort received an immunization notice from Public Health, with just over 8,700 students receiving a suspension notice. And on the first day of the suspension period, there were 1,848 students who are still overdue with immunization information, and they did face exclusion from school. By the end of the suspension period, which was 20 days, we ended with 194 students still remaining on the exclusion list on the last day of the suspension period. Next slide, please. So this is just a little snip of some of the service delivery outcomes from the start of the 2024-25 immunization record review process to the start of the suspension period. During this time frame, the vaccine program answered just over 13,600 phone calls. We held vaccination clinics at over 30 secondary schools between the end of January and beginning of March, and we administered vaccinations strategically at select elementary schools, as well as designated sites for alternative learning students and Indigenous community members. The number of unique students with exemptions processed, combining philosophical, medical, and administrative, was 727, with just over 600 of those related to philosophical or religious reasons. However, it is important to recognize that many students with exemptions on file still do have partial and sometimes complete immunization records on file with Public Health. Now moving to this year's record review for the 2025-26 school year, there is a slightly larger student cohort with just over an additional 1,600 students than the last immunization record review. But there's also a lower number of students, by just over 2,000, who received an immunization record reminder notice. So we're in a little bit better shape than we were last year. Of this, just under 73,000 students currently enrolled in schools in Niagara. There are just under 59,000 students aged 7 to 17 years and just over 14,000 students who are 4 to 6 years of age enrolled currently. So of the 11,694 immunization record reminder notices recently sent out from public health, just over 9,000 students are 7 to 17 years of age, and just under 2,800 students are between 4 and 6 years of age. So based on these numbers, public health anticipates there's approximately 7,100 students who are elementary aged and approximately 4,400 students in secondary schools. So your office may be hearing from some families of students with incomplete vaccination records. Some may be asking for their immunization record, and some may require vaccine administration. Public health will be offering secondary school immunization clinics for students who received an immunization reminder notice and are currently in grades 9 through 12, along with some clinics for the wider student population. However, there will not be enough clinic spots for every student who is overdue in Niagara. So public health will prioritize students who face barriers to accessing vaccination services. Please consider offering vaccination to patients who are due or overdue for vaccination, particularly those patients who are in elementary school. The next slide, yep. To fully capture the intent of the Immunization of School Pupils Act, Niagara is really focusing on using the overall compliance rate as an indicator of success. So compliance with the ISPA means that each student either has the required immunizations or a valid exemption on file with public health. So during the 2024-25 immunization record review, Niagara's compliance with the ISPA for children 4 to 17 years of age increased from just over 80% in January of 2025 to just over 93% in May of 2025. However, since May of 2025, additional students have become eligible and due or overdue for vaccination based on their age. So Niagara's compliance rate with the ISPA in October was just over 84%. So as with previous years, many of the students who received notices from public health are already up to date with immunizations, but have just not reported this information to public health. I'll review the process for reporting vaccine-related information, including where and how to submit records in the coming slides. However, based on experience, many will require vaccination, and some will have more complex immunization records that will require a schedule of vaccinations to be developed in order to bring them up to date. And Jenny will go over those specifics shortly. But for the 2025-26 immunization record review, we anticipate that fewer students will be suspended from school, as suspension will be enforced for students aged 7 to 17 years of age if the information on file with public health is not up to date by the beginning of the suspension period. This year, and in alignment with pre-COVID practices, students 4 to 6 years of age will not face suspension from school, as these younger cohorts are in a critical stage of social, emotional, and cognitive development where consistent school attendance is essential. Additionally, in many cases, missing documentation rather than lack of immunization is the primary issue for these younger students. Public health will continue to work proactively with families to update records and support immunization compliance while maintaining school attendance for younger children, and a second reminder notice will be sent to families in the new year. All the key dates are now outlined on our website. We've created a new page on our website, and I encourage you to bookmark this page and review as needed. Please also let your patients know about this site. We're including a QR code in the letters that we sent out to students and families that brings them to this site as well. So during early to mid fall of 2025, so we just finished this part right now, public health begins the reviewing of student immunizations, followed by the mailing of reminder notices to students and families just this past November. So this is completed as well. In January of 2026, students and families who still have incomplete information on file with public health will receive an order of suspension, and this will be for students 7 to 17 years of age. And a second reminder notice for students 4 to 6 years of age will be sent out. This gives families plenty of time to update records before the actual suspension period begins. So during the end of January and into the first part of March 2026, public health will host in-school vaccination clinics at participating secondary schools. Secondary students who receive an immunization record reminder notice from public health can attend the clinic at their school. We're requesting that all missing information be submitted to public health by March the 9th. This will allow for processing time to update the records on file. Public health is also planning to offer daily clinics throughout March break, and these will be actually held in a hub model across the region at different schools who are opening up their doors to students within their catchment areas. This will be for students 7 to 17 years of age who have received a suspension order, and these clinics will be scheduled, like I said, in various schools throughout the region. The suspension period this year begins on March the 24th, which is the Tuesday after March break for students 7 to 17 years of age. And this is the time when students with incomplete records may be suspended from school. As a reminder, when a student is flagged as due or overdue for vaccination by public health, it's based on the information that we have on file for that student at public health. The immunization record that public health has on file can be accessed by the student or their family if they're younger than 16 years of age through Immunization Connect, otherwise known as ICON. This year, public health included a copy of that record that we have on file for each student with the immunization record reminder notices that were sent out. Please remind your patients when you're booking them an appointment to bring this record with them to their appointment. You can find a sample of an ICON record, a PDF document that was attached to your calendar invite for this education event this evening. A few things you should know is that what is in a patient's ICON printout is what public health has on file for them. So in order to determine the type of vaccine product received in ICON, you need to go to the far right column under the additional info section. If your patient's record in ICON is up to date with what your office has on file, you can provide them with the vaccinations as indicated by public health in their reminder letter. If your patient's record in ICON is not up to date with what your office has on file, provide any missing vaccines if required. And if you're unsure of the vaccinations required for the patient to be up to date, just give us a call at public health. And you can also give the parent or legal guardian an updated record and advise them to report the vaccines to public health. It's helpful to also include the type of vaccine received so that those details can be added to the record. At the bottom of the ICON record, there is an immunization needed section. This section is not specific to only ISPA vaccines. For example, it may also indicate if Hep B or HPV is required for a teenager who perhaps missed their grade 7 vaccines. So having this additional information could be helpful because it might be a good opportunity to immunize your patient forever they may need and be eligible for. Despite ongoing communication efforts, there seems to be a general lack of awareness about the requirement to report vaccines received to public health, as many students may be up to date, as I previously mentioned, but just have not reported this information to public health. The vaccine program has some resources available to help increase awareness of the reporting requirements. A reporting resource can be ordered through the website. These notification tariff pads can be provided to patients following immunization. This on the screen right now is just a snip of the resource, but it instructs patients on how to report vaccines using ICON. The full resource outlines other ways to report vaccines to public health, such as mail, fax, or drop off at a public health office. These details are also available on our website as well. You can order a poster for your exam rooms or waiting areas on how to use ICON as well if you're interested. And before I hand it over to Jenny, just a few reminders on vaccine ordering. Please only order what your vaccine fridge can safely hold and accommodate. I know a lot of the vaccine products are coming in larger packaging now, so just being really cognizant of the space that you have and what you can order. All vaccine orders must be accompanied by a current 4-week temperature log up to and including the present day. The deadline to submit your vaccine order is 3 full business days prior to your delivery date. So the day of delivery doesn't count. So for example, if your delivery is on a Thursday, like December the 18th, you would need to submit your order by end of day on Friday, December the 12th. Because the program staff require time to process and pack all the vaccine orders that are always coming into public health. So delivery of the late orders will need to wait until your next scheduled delivery date. And due to capacity right now, vaccine pickup is not currently available. However, we are currently completing a review of the vaccine ordering and distribution processes. Therefore, please stay tuned for any updates that we may have for the new year. So now I'm going to hand it over to Jenny to talk about immunization records in more detail.
Would be helpful if unmuted. Thank you, Leslie, and good evening, everyone. My name is Jenny. I'm one of the supervisors with the vaccine program, and I will be talking to you about how to assess what is needed to bring your patient's records up to date. There's a focus on ISPA compliance, but we will also talk about other publicly funded vaccines as well. So specifically, we'll talk about reviewing your patient's immunization history and determining which vaccines they need, and creating clear vaccination plans for patients with more complex records to bring them up to date. I will start by walking you through 2 sample records. After that, we'll get into some knowledge testing quizzes through Menti, and then if there's time, we will review some records as a group. For some background, these records are based on real records we have seen in our program. However, dates have been altered slightly to maintain confidentiality. We will assume that the records that we present are complete and accurate, and I will discuss minimum intervals and recommended intervals based on Ontario's publicly funded immunization schedule. I will also post answers into the chat when we get onto the slide, just so you're able to follow along more easily, since the record will be the thing shown on the picture. So, this is the first sample record. I clicked, but it's not advancing. There we go. Okay, so this is for a child who was born 2013, February 18th. And as you can see, they have had quite a complex immunization record. This child would be 12 years and 9 months of age. And for something like this, which is incredibly complex because they've got lots of separate antigens, I do recommend looking at the antigens individually to see if they're complete or incomplete first, and then grouping them together to see what vaccines you would need based on the antigens and this child's age. I want to note that on records like this, a lowercase means low antigen. So for diphtheria, for example, at 1 month, that would be a low antigen because it's a lowercase, and uppercase would mean high antigen. Something unspecified means that we don't know about the antigen or about how it's the components of it. So for example, when we look at P unspecified, that's an unspecified polio vaccine. So we don't know if it's an IPV or an OPV. Like we don't know if it's injected or if it's oral. So to start with kind of the tetanus containing group, which is largely based off of table 24 in the publicly funded schedule. Again, I would look at them separately by section. Looking at tetanus, that one's good. This child has had 4 doses. Their final dose is after the age of 4 and more than 6 months from the last one. So their tetanus is actually fine and up to date. However, they are missing both high antigen diphtheria and pertussis, because when they are between the ages of 4 to 6, they do require the pediatric formulation, which is a high antigen diphtheria pertussis. And they've only had 1 dose of high antigen, which is after the age of, the age of 6 months and 6 years and 4 months. So the other diphtheria and pertussis would not be valid because they're low antigen. So they do need more diphtheria pertussis vaccine. Their polios are good. Their first dose of polio would not be valid because it was given way too early at only when this child was 5 days of age. However, their other polios are at good intervals. Their last polio is after the age of 4. And because this child got all of their unspecified polios before April 1st, 2016, we don't need to worry about whether this unspecified is a IPV or an OPV. So, looking at all of that as a group, polio's good, but they need more diphtheria and pertussis, and you can't get those without tetanus in Ontario. So if you look at table 24 and this child has had 1 dose of high antigen under 7, then they will need 3 more doses of that following the schedule. Because they don't need polio or Hib, and they're obviously too old to get PDSL at 9, they would just be due for Tdap. The other vaccines are far easier. Meningococcal, they are done. They have had their 12-year MenCACYW 135, so Menactra or Nimirex or Menquadvi. Stay tuned for that announcement. And that also contains MenCC, so they are good for meningococcal. For measles, mumps, rubella, and varicella, they've had one valid MMR at 6 years and 4 months of age, so they've got one. Their measles and their varicella at 9 months of age would be too early because they were given under 12 months of age, and that we do not consider to typically confer long-term protection. So they will need one more measles and mumps and two more of rubella. Sorry, two more of varicella. They do not need any more rubella technically because they only need one as per ISPA, but you can't get rubella, but you can't get measles and mumps without rubella. So they need more MMR. And because they need both MMR and varicella, and they are between the ages of 4 to 12, so they're less than 13 years old, they are able to get MMRV, which saves them a poke because then you can give them MMR and varicella together. If we look at non-ISPA, they do need another HPV-9 because they're on a 2-dose series, but they're not quite due for it yet since they only had it in November, and we need a 6-month interval. So you can't give them anything on this visit if they were here with us today. Their Hep B is actually complete. They've completed a 3-dose pediatric series. They've actually got, I think, a bit more than 3 doses, but they've got a full series of Hep B. So their Hep B is actually complete. So therefore, if they were sitting in front of you, we would recommend that we give a Tdap, so an Adacel, a MMRV, and then in 2 or 3 months, they could come back for a varicella and a Tdap. And then 6 months after that, they can come back for another Tdap. And the reason why I say 2 or 3 months for a varicella and Tdap is because the recommended intervals for those in the publicly funded schedule are a little different. Recommended is 2 months for Tdap, but 3 months for varicella. The minimum for varicella, though, is 6 weeks. So in an ideal, perfect, beautiful world where you have all the time in the world, you can absolutely see them at 2 months and then again at 3 months for those vaccines. But we recognize that in the real life, you have a clinic to run and your patients have typically a life outside of coming to your office for vaccines. So at our clinics, we would likely group them together for the patient's convenience, in which case you could do 3 months, which is the longest recommended interval, but it wouldn't be wrong either to do 2 months because you can do varicella with the minimum of 6 weeks. Or again, if your patient really does prefer to split them, you can do that too. But there is some leeway depending on patient preference, your assessment of their risk, things like that. So that's kind of one record to go through. And then I have one more that I will just run through with you. So this is sample record 2. And let me just paste the answers into the chat so that you are able to follow along without having to memorize what I'm saying. So this child is born 2022 May 4th, so they would be 3 years and 6 months of age today. For someone like this, where they obviously had combination products and they look pretty good, I would recommend looking at the combination products. So in this case, the DPT HB HIP. So DPT Hep B HIP, which is something given largely in other countries as a group. They started their DPT Hep B HIP at 6 weeks and 1 day of age. So that first dose is valid, despite it being earlier than 2 weeks. And their DPT series actually follows the publicly funded schedule quite well. Their 4th dose was at 17 months, not 18 months of age, but that's okay because those 4 should typically be at age greater than 1 year and 6 to 12 months after the 3rd. So they're good on that one. This is though a situation where we are going to make available a quick reference guide and a quick reference chart for ISPA. But this is a clear-cut situation where the recommended number of doses will be more than the minimum that's needed for ISPA. And that's why it's always really important to look at the publicly funded schedule for the children in your practice. HIB is not ISPA, but if you look at Table 8 in the publicly funded schedule, and you look at this child's HIB series, you can see that they had their last HIB at 3 months of age, and they haven't had any other HIB since. So they should have a dose over 1 year of age, so they should need one more HIB. Similarly, the other problem with this record from an ISPA perspective is polio. They have not had actually any valid doses of polio. They received oral polio after April 1st, 2016. So that's a date when a lot of countries switched to bivalent oral polio, instead IPV is trivalent. So children do need to receive that third type of polio, or that third strain of polio, sorry, in order to be fully protected against the polio virus. So any polios received after April 1st, 2016, if they're oral polio, it would not confer them enough protection. So they do need more polio. If your eye is super keen, you might have noticed that they did get one IPV on August 18th, 2022. Unfortunately, that is also not valid, because if you look at it, you can see that it was given at the same day as an oral polio, and that is something a lot of countries will do. However, when they do this, what they actually give is a fractional dose of a IPV, so a partial dose and not a full dose. So that also wouldn't confer full protection, so they actually have no valid polios. Now, there's a couple things you can do with this child in this situation. If you follow the word of the publicly funded schedule, technically it would be a 4-dose polio series for this child because they are under 4 years of age. That being said, you can also get away with just giving this child 3 doses, which is 1 now, 1 in 2 months, and then you would make sure that you give their 3rd dose after they've hit the age of 4, and you can give it in the regular Tdap IPV that kids between 4 to 6 would get. So those 3 doses, as long as the last one is over the age of 4 and more than 6 months since the second polio, the 3rd dose would complete their polio series and give them that protection. You can choose to follow the public funded schedule to the word and give a 4-dose series if you are very worried about exposure. Typically at our program, for patient convenience and autonomy, we would at least offer them the choice of doing a 3-dose, which is, a lot less visits for the patient and less pokes for that child. Other easier things to look at, men-CC, they will need 1 dose. What they have is unspecified at 1 year and 5 months. So we don't know if it's what it is. We don't know what kind of meningococcal vaccine it is. We don't know if it's a conjugate vaccine or a polysaccharide. We do require conjugate vaccines in Canada, and we don't know if it's against the C serotype. So we do need a men-CC for this child. For MMR, they have had technically 1 valid dose of measles and 1 valid rubella vaccine at 18 months, so 1 year and 5 months. Their 9 month, again, would be too early. They do need 2 doses for ISPA, and similarly, they do need 2 doses of varicella for ISPA. They're only 3 years and 6 months old, so you wouldn't give them a second MMR, or sorry, you would give them their first, but you wouldn't give their second until after they hit the 4 to 6 mark. For pneumo C15, not ISPA, but they do need, if you follow the ministry guidance that they sent out for the pediatric pneumococcal, they do need 1 dose at this age. So currently for this child at a clinic, they could get basically 6 vaccines on this visit if they were sitting with us today. And that would be HIB, IPV, men-CC, MMR, varicella, and pneumo C15 now. And then they would get men-CC, and then they would get IPV in another 2 months. After that, you can give them routine Tdap IPV and MMRV after the age of 4, ensuring that the intervals are met. So those intervals would be 6 months between the second to the third polio and 3 months between MMR and varicella and MMRV. You cannot combine the MMR and varicella just yet because MMRV as Proquad would only be able to be given to kids who are between the ages of 4 to under 13 years of age, and they're not quite that old yet. So you would give the MMR and the varicella separately. As a bonus to this, if this child's family immigrated from a country with high Hep B prevalence, which they might have because they've gotten a lot of like 2 doses of Hep B vaccine or 3 doses of Hep B vaccine as an infant. So if they immigrated from a country with high Hep B prevalence and they might be exposed to Hep B carriers through their extended family, then they are qualified for high-risk Hep B. And they would just need 1 more dose to complete the series. So they just need 1 more dose after the age of 6 months. I am missing a check mark, but it doesn't change the fact that this child is not complete their Hep B series. So those are some more of the more complex records that we have seen historically in VPD. And I am sorry about missing the check mark for the 3-month Hep B. I was recreating these, as you can tell. So next we are moving on to Mentimeter, although I see someone has a question if you wanted to ask now.
Yes, hi, thank you.
Oh.
I just have 2 quick questions. The polio vaccine, if I understand correctly, the minimal requirement then would be 2 doses of course, a valid IPV, not the oral, after 2016. And then the third one would be at the age of 4 or older. So that would be the minimal requirement for anybody. Say that a child is 5 years old and we have to catch them up. They would technically just need 3 polios.
That's correct. That's correct. So if you go strictly by the word of Table 13 in the publicly funded schedule, it will say that if they have their first dose between 6 weeks and 3 years, they could get up to 4 doses, but they don't need a 4th dose if their 3rd dose was given over 4 years of age and at least 6 months after the 2nd dose. So as long as the intervals are there, they do not need 4 doses of polio.
So if they
Some
had
kids.
2 doses,
Sorry. Yes.
if they had 2 doses, say before 1 year old, and now this child is 4, they can just get an Adacel polio and they're good.
Exactly.
Like
yes.
Okay.
Yes.
Okay.
If you do end up needing to give more polio because you have to give a PDSL for the high antigen or Pentacell for the high antigen, they're the same thing. Then they end up getting more polio, and that's okay. But they don't. If you're giving individual polios, 3 is the most.
And
3 is the minimum.
Perfect. Thank you. And the MMRVs, we see often that the MMRVs are given together as 2 doses at 12 months and 18 months in Quebec or elsewhere. They're not given separately. So if we have a client that comes to our clinic and they've got 2 valid doses of MMRV, even though say 2 Proquads or prior Tetras, and they're over a year old, the minimal delay is respected, those are considered valid. There's no need to repeat that, correct?
Correct. So if they got a combination product under 4, that's okay. Public health considers them valid. We just don't recommend administering that way because based on the research, there's an increased risk of febrile seizures with the combined Proquad product when it's given under the age of 4. So that's why in Ontario we don't do it. It's to decrease the risk of side effect, essentially. That's the main reason, at least.
If we would explain that to the family, because say this child needs 5 vaccines as opposed to 5, we could combine the MMRV together and make it 4 injections. And the parents ask for that, are we allowed to do that?
That's a hard question to answer. I mean, you have the vaccine. Oh, Dr. Kasmani's putting his hand up. Okay.
Okay,
Sorry, it's a little loud in my house. My children are just getting ready for bed. I think the main reason, so in other provinces, they do offer it an MMRV, and it's offered earlier than 4 years old. The challenge is that it can be, there's no real significant harm to febrile seizures, but when they do happen, it really scares parents. And then they get worried, and then there's that higher risk of vaccine hesitancy in the future. I could imagine if my kid had a febrile seizure, I would be freaked out. And I know there's nothing wrong, but even knowing that, it would be really hard. And so that's the main reason that the recommendation is. I think, can you give it? Yes, knowing that, but it's balancing that one extra vaccine versus the potential side effects down the line. Ultimately, it's a decision you make. The recommendation we would give, based on our provincial guidelines, is to give the separate products.
okay, thank you.
The other thing to add is that technically it's not publicly funded for those under 4 years of age as well. Although I understand you have the you likely just have the product in your practice already. But yeah, like we wouldn't say that you have to get it again. Okay. So it looks like we are having some technical difficulties. Oh yeah, and the other thing to mention is that if you are seeing a patient in your office with very complex records, at least 2, please also feel free to call us and we can help you review it as well if you'd like.
And if I can just add to that, please do call, because we don't want the child to get the wrong vaccine. We have seen in the past they might get a product that's different, and then they may have a catch up, or they may say, oh, I've already got this and need to get something. So we're more than happy to provide some consultation on that to help make sure you can give the right doses and answer questions like the ones you just asked about MMRV as well.
Thank you, Dr. Kasmani. Okay, so any other questions before I move on to the Mentimeter? Great. Okay, so we are moving on to Mentimeter questions. The questions are kind of long, and these are harder than the ones at the start. So I will post the question into the chat, just because once we get to the part where you would answer, you you won't see the questions. Dr. Kasmani, I mean, you can use whichever books you'd like, but I don't know how long you want to spend on this.
I always have the schedule open when I'm answering these questions.
Sure. Is 2 doses of mumps needed under ISPA? So that's a good question. And the answer is very technically no. Like you only actually need 1 dose. Sorry, mumps. Sorry, I was thinking rubella. Yes, you do need 2 doses of mumps under ISPA. It's rubella that you only need 1 dose of under ISPA. But they all come together, so it's kind of hard to get away from one of them. Okay, so our question, in case you didn't see it before, oh, my text is going in big. Okay, cool. So our question is, an 8-year-old presents at your clinic. He has gotten MMR at 9 months of age, MMR at 12 months of age, and MMRV at 13 months of age. I've put the intervals between doses in brackets, just so we're not tricking you with like, oh, it was 12 months, but it was actually 12 months and 1 day. So the question is, which of these is he due for now? So A is varicella only, B is MMR only, C is MMRV, D is MMR and varicella, and E is nothing. He is fully up to date. You're not being graded on this, don't worry. We will not hold any of these against you. So see if this is working for you. Okay, so, oh, sorry. I will give the answer first before we move on. So the correct answer is actually C. He is due for MMRV. And the reason for that is because, as everyone probably thought, the MMR at 9 months old he is too early. It's not over the age of 1. It would not count towards ISPA. The MMR at 12 months is valid, so he's good on that one. The MMR at 13 months with a 4-week, the MMRV at 13 months with a 4-week interval is actually also not valid when you look at table 16 of the publicly funded schedule. When you give MMR and then MMRV, it actually requires that you have a minimum interval of 6 weeks. And that's due to the risk of immune interference. So going by the publicly funded schedule, we would recommend this child a MMRV, and then we would recommend they get a varicella 3 months later. Sorry, so question 2. So this is a 16-year-old girl who comes to your clinic. She has received the following. So at 11 months, MEN-CC, at 12 months, MEN-CACYW 135, at 12 years and 6 months, Hep B and HPV 9, and at 12 years and 8 months, HPV 9. So which of the following vaccines is she due for now? Your choices are A, MEN-CACYW, B, HPV 9, C, Hep B, D, which is all 3 of those, or E, just B and C. So just HPV 9 and Hep B. And again, MEN-CC at 11 months, MEN-CACYW at 12 months of age, and then Hep B at 12 years, 6 months, and HPV 9 at 12 years and 8 months. Perfect. Thank you for answering. So stay on this question for now. So the correct answer is B, all 3 of those. And this is a bit of a trick question, so I'm glad that none of you were tricked by it. She does not need any of these vaccines for ISPA, actually. MEN-CACYW at 12 months fulfills both the MEN-CC and the MEN-CACYW ISPA requirement, even though it doesn't follow the publicly funded schedule. But she is still recommended to get all of these vaccines still, and she would still be eligible for MEN-CACYW since that eligibility kicks in once someone is in grade 7. And we would recommend it for protection because the immunity that she would have gotten from MEN-CACYW at 12 months would have waned by the time she's 16 years old for sure. So the MEN-CACYW, grade 7. For HPV 9, as you said, she would need, because she got a second dose at 2 months, that puts her on a 3-dose schedule for HPV 9. So she would need 1 more dose to complete that series. The HPV 9 series, by the way, depends on when someone started with the series. So if they started on a 2-dose schedule, they're always on a 2-dose schedule. The Hep B, she is no longer able to complete a 2-dose series because she's aged out of a 2-dose series. So I didn't ask this, but she would actually need to do a 3-dose series of Hep B. So 2 more doses of pediatric Hep B, 1 now and 1 5-month-old. And that's because when you look at the publicly funded schedule, the Hep B series depends on how old someone is now, which is a bit tricky because the HPV depends on when they started their series, and the Hep B depends on their age now. So that's why she would actually be recommended 2 more doses of pediatric Hep B to complete that series. Not that that's part of the question. Question 3 is, so this is Billy. He is aged 14 months. He has been brought to your clinic by his mom for 1-year vaccines. After vaccination, you tell him that the next appointment would be for Billy to get his chickenpox vaccine. Mom tells you that Billy had chickenpox 3 months ago. So which of the following would you do? And I'll read these out there. I'll maybe post the answers in the chat too, the choices in the chat too, just because I can recognize they might be a bit harder to read. So choice A is to book Billy into a clinic in 4 months for his pediacel or penticel and varicella. Give health teaching that varicella disease Or B is give health teaching that varicella before the age of 1 does not give sufficient long-term immunity, so he should still get vaccination. C is to book Billy into clinic 3 months for his varicella and MMR. D is to book Billy into clinic in 1 month for varicella. And E is to tell him that he does not need varicella since he's got the disease and you would write a medical exemption. And F is both B and D. So B and D would be to give him health teaching that it doesn't give long-term immunity and to book Billy in 1 month for his varicella. So give him a couple more seconds for more people to think about this and answer. Great. So I'm not catching anyone with this trick. So the correct answer is F. Varicella infection only gives long-term immunity if it happens on or after 12 months of age. So his having disease at less than 12 months of age has been associated with an increased risk of a second episode of varicella. So we would recommend the vaccine. MMR to varicella is a 1-month interval as per table 16 of the publicly funded schedule. So assuming that you're giving him his routine 1-year MMR today, he can still get his routine varicella at 15 months of age, as long as you make sure that it's actually like a month and not like, say, he's 14 months and 20 days today, and you're calling him back in 10 days. But as long as you make sure that there's a month, you are good to go. Okay, so question 4. So a parent comes to your clinic because they were told their child's polio vaccine wasn't up to date. Their child is 8 years of age and has gotten several doses of OPV, some of them along with IPV on the same day. So which of these health teaching options would you give them? And next page, please, with the choices. Thank you. So your choices are A, to give them health teaching that OPV after April 1st, 2016 are bivalent, which would not give full protection. B, based on their child's age, they would need 3 doses of IPV. C, there is a glitch in the system, the doses should be valid. D, IPV given on the same day as OPV is a fractional dose. And E, you would give them you would choose A, B, and D. So you would tell them OPV is a bivalent vaccine, it doesn't give full protection. They will need 3 IPVs and IPV on the same day as OPV is a fractional dose. So yes, we just went through this. Okay, we just went through this and thank you for paying attention. So that is correct. Answer E is the correct answer. Okay, so question number 5, and thank you, Dr. Ma, for doing my copy pasting for me. My words are pasting really big for some reason. Okay, so question number 5. So a 15-year-old presents to your clinic. She received her Tdap, IPV, and MMRV at 4.5 years of age. And she had a TD vaccine at the hospital 1 week ago following an injury. So the question is, what is the recommendation for her tetanus-containing vaccines? So your choices are A, she needs to wait 2 weeks between vaccines. B, she is due for Tdap vaccine now. C, she will only be due for Tdap vaccine next year because she is not yet 16. D, a TD is adequate protection and she doesn't need any more vaccines. Or E, the hospital probably documented incorrectly and she got a Tdap. Okay. Thank you for answering. So you are correct. The answer is B. She is due for a Tdap vaccine now. So there is a 10-year between Tdap and childhood vaccines, and a TD doesn't count because it doesn't confer enough protection against pertussis. I do have 5 more questions. I will fly through them really quickly because I recognize that we are at 7:48, so we may not have enough time for everyone to do the answers. But number 6 is that a dad brings a 6-year-old to your clinic. He's got a 7-week PDSL, a 21-week PDSL, a 24-week PDSL, and a 5-year Tdap IPV. Is he due for anything? And the correct answer is, I will just give the answer since we are running short on time, is E. He's due for a PDSL. And this is because the first dose is valid, the second dose is valid because the intervals are good. The third dose is actually not valid because the minimum interval between doses is 4 weeks. We need to give the immune system time to mount a response. That also means that the last dose is not valid since it should have been a PDSL. Technically, the tetanus and the IPV are valid, but the diphtheria and pertussis are not. And since this child is under 7, they do need a high antigen in that case. Question 7. Sorry, just flying through these very quickly. Question 7 is, what would you give him next? And what we would recommend giving him next, if you flip to the answer, is a Tdap IPV in 6 to 12 months. And that's because at this point, when we look at table 4, he's got 3 valid high antigens. Table 4 technically tells us to give a Tdap IPV, but when we look at his schedule series, his IPV series is already complete since he's already got enough IPVs. So we don't want to give unnecessary vaccines, so we can give this child a Tdap. I think I might just skip the next 3 questions so we can move on to the question answer period. If that's okay. Sorry, it's great. We have spent lots of time. There were lots of really good questions though, so thank you. So I did also have some sample records to go through with everybody. We do appreciate your participation in these interactive components and for you responding to these as well. We do have a new resource coming out for healthcare providers, which I've alluded to, which is a table that discusses the minimum intervals for the Immunization of School Pupils Act and the minimum required. As a full disclaimer, again, as we've shown, it is always important to use your clinical judgment and to refer to the publicly funded schedule as well, since that is just one document and it doesn't capture all of the nuances. And that resource will also be available to order from our webpage, where you can order clinical and patient resources. And that brings us to our question and answer period.
Okay, there we go. Okay, hi, everyone can hear me okay? I'm gonna plug in the first question into the chat. Yeah, it's not copying and pasting. Give me a second here. You know what, I'll read this first question out loud, and Leslie, if I could have you on standby to answer. So one of the questions that came in was minimal dose requirements for Tdap, polio for different age groups, guidelines Hep B adult versus junior dosage, free coverage criteria Hep B, and also part of that is, why is MMR and varicella given separately as opposed to 2 doses of Proquad, creating catch-up schedules? So there's a lot packed into that one. So Leslie, I'm going to try and get that back and to copy and paste it into the chat so people can follow along, but I'll let you start answering.
Okay, this is, excuse me, great question. I think that the presentation, we did go over the minimum requirements and guidelines for different age groups. Jenny did cover that in some of her examples. And as she mentioned, we are creating a 2-page resource that will be available. And in there, we've actually outlined a lot of the minimum intervals and what we'd be looking for certain age groups in terms of tetanus-containing vaccines. The guidelines for Hep B adult versus junior dosage. So Hep B adult versus junior is according to the publicly funded schedule. So table 6 of the schedule provides a 2-dose schedule for children between 11 and 15 years of age. And table 7 provides the 3-dose schedule. So children are routinely eligible for hepatitis B vaccine once they are in grade 7. So it's based on school grade, not their age, goes by school grade, and they remain eligible now to complete their to start and or complete their series by the time they finish high school. If they have any other criteria that I think this question is also asking, when is it free? So there is we have this in our desk all the time. It's the publicly funded schedule. So if you refer to table 3, which is a high-risk vaccine programs, it does outline in there all of the eligibility outside of the routine school-based program eligibility. Why is MMR and varicella given separately as opposed to 2 doses of Pro-Quad? We did answer that earlier in the presentation. And creating catch-up schedules can be really, really tricky. So as we mentioned in the chat, if you have these complex records coming in and it's difficult to kind of make sense following the catch-up schedules written in the publicly funded schedule, then please do give us a call and we'll help you work through that and set up a plan for your patient. I hope I answered all of the parts of that.
Good. Okay, great. We've got our next question. Discrepancies in timeline of vaccines between provinces, and what do we do? Leslie,
Yes,
again?
Yes, I think, Marcy touched on that in her question when she was asking about the Quebec schedule and having MMR given at an earlier or MMRV given under 4 years of age. I think this is when you need to assess the antigens individually and exercise your clinical judgment. And we hope that this presentation was helpful in providing some information on how to do this, as the Immunization School Pupils Act is specific to Ontario requirements. So we often see this with people who come from either out of country or out of province because they're just on a little bit different schedule. So the ISPA is Ontario specific. So we have to, we try to do some education around what's the requirements for Ontario.
Okay, so I still have 2 more questions that were submitted when the registrations came in. However, they aren't specific to ISPA. We're happy to answer them. I just wanted to open up the floor first, though. Is there any other questions pertaining to ISPA or to the presentation tonight? Just feel free to raise your hand or type in the chat. Okay, yeah, Marcy, go ahead.
I just wanted a clarification because there's many vaccination records that are from other countries, Haiti being one of them. And often I see on their booklet, it's pentavalent, and then a polio is given the same day. So I'm assuming that the pentavalent is not a pentacell, it is a pentavalent with a hepatitis B included minus a polio. Am I correct on that? Like, is that something that, 'cause I see it a lot.
Yeah, you know what, Marcy, I can look into that a little bit further because I'm not familiar with all of the different ones that they're given in different countries. So I will look into it further. There are some countries, you are correct though, that will give, a combined product that has an IPV component to it along with an oral polio. And in those instances, those rare instances, that IPV or that polio that's part of a pentavalent vaccine might be still valid. But let me look into what they're giving typically in Haiti, and then I can get back to you on that one, okay?
Yeah.
If
so
I
the
can,
the pentavalent wouldn't have the polio in it. I see it written separate. That's why I'm thinking.
Oh, okay.
It's got the diphtheria, tetanus, pertussis, Hep B in there instead of the polio. So, okay, but we could follow up. That's great. Thank you.
if I can add one thing though, something that you could do if they are under 18 is to encourage those parents to report their vaccination to us first, because we will put their vaccination record into Panorama. The parent would be able to access through Icon, and then you'll be able to see what vaccine it is. It's not a question I can answer off the top of my head either, because some pentas, you are totally correct, are DTaP, IPV, and Hib. And some are different. There is a WHO website that gives the vaccination schedule for different countries. I will put it into the chat. It's not loading for me right now. Like the list is telling me that there's an unexpected error. So it's not loading for me right now, but typically this webpage tells you what the typical schedule is for any given country. And it would say what kind of vaccine they normally get. So I've put that in the chat for you. And I think Susie also asked the same thing. So yeah, sorry. It's giving me an error, so it's not working right now, but it should be working.
Okay. Okay, so we're at 7:59 right now. There are a couple other questions in the chat. There was two we didn't get to. So be mindful of everyone's time. When you get your follow-up email, that's going to come with your certificate, and we'll have that 2-page resource that Jenny referred to in it. We'll answer some of these questions. Yes, Dr. Kosmani.
Just quickly, I want to thank everybody for putting this together. I especially want to thank everybody for joining. It's really important for us. And, I will quickly give my 2 cents on Dr. Deck's question there about people responding to warnings. And I do think, your attendance here is important in this because it takes a village. And we know from the WHO and the vaccine hesitancy framework that convenience, complacency really affect how long people take. So this helps reduce complacency, but also convenience and confidence. And I think you have a big part to play in this as family doctors. And family doctors are they're trusted sources that people go to for their information, and they believe everything you say. And so when they come to you and you provide that vaccine, if they're coming to you for another reason and you provide that vaccine on that visit, it really does make a big difference. And we notice people who have that committed family doctor, we're dealing with them less. And so you have a big role to play in that. And just your presence here, we really appreciate, because it helps us to get to that place where we can all be vaccinated. We can all be on the same page. You know that we're there to support you. If there's challenges you're having, we're there to support you. I'm always here to listen. I know Leslie's team does a wonderful job responding to feedback and trying to make things as easy as they can for you. And I hope you got that through some of the answers. I know the situations that were presented were quite complicated, but Angela was messaging me separately and saying, wow, everybody's doing so well on these. And I was telling her, don't worry, your fellowship exam won't be this difficult. So there are resources there for us to review. We're there to support you and to be on the same page. Those resources that were provided, like the card, etc., we'll do our best to provide you hard copies of them if that's helpful. Whatever we can do, because we see, like during the measles outbreak recently, if those folks had been vaccinated, how much less work it would have been for us in the moment. And so the prevention is really worth so much more than all the work afterwards. So thank you so much for joining, and thanks to the team for putting this wonderful session together.
Thank you, Dr. Kosmani. Just 3 takeaways from tonight. Take every opportunity to immunize and prioritize patients in elementary school. As Leslie had referred to earlier, we're going to have clinics in secondary schools, and so we really appreciate any effort with the elementary students. Please remind parents and guardians to report vaccines to public health, and of course, access the tools on our website. And finally, if we could just go to the next slide, watch for our email. We're going to include your certificate of participation, link to the evaluation, and a couple other items. Thanks again for your time, everyone. Appreciate it. Have a safe evening.